So today we're talking about quality care at hospitals and medical tourism and what that means. There's a lot that goes on behind the scenes to ensure a good standard of care. And we're so pleased to be speaking with the Aga Khan University Hospital CEO, Rashid Kalani. Thank you for speaking with us on this issue.
Thanks for having me.
So most patients have their sort of point of contact, with the doctors or with that system, but there's a whole other system that goes on behind the scenes to ensure quality care and accreditation that goes with it. So the Aga Khan University Hospital is among the institutions in the world with what is known as JCI accreditation. Talk to us about this, what this accreditation is and what it means for patients.
Okay. Again, thanks for having me. JCI is one such certification or accreditation. There are several others that exist. Why is it important? Like you said, that when we talk about patient care, it is really dependent on not the quality of the building or the quality of the equipment, because anyone with the money can buy a building, build a building or buy an equipment. But what the clinical outcomes are, if you come for a heart attack, if you come for a stroke, if you come for a surgical procedure, or if you come for cancer care, what is the quality of care or the clinical outcomes that we provide to the patients? That is important. And the devices or the buildings will not measure it. There has to be an external party, an international body that has to look at your standards, it has to look at your processes, it has to look at your systems, it has to look at the people that you employ and their qualifications and their training programs, which will then, they will benchmark you against the best in the world. And that's what our journey is all about. That's what Aga Khan's quality journey is all about, that we invest in people, we invest in technology, but at the same time, and very importantly, we invest in quality. We have to make sure that the care is standardized. And I have said this in previous conversations, that it is easy to compare one hospital with the other based on pricing. It is easy to compare one hospital with the other with the size of the hospital. 300 bed, 300 bed. MRI is 30,000, 30,000. But are we comparing apples to apples? Is the quality of care same? Is the clinical outcome same? From infection rates to the readmission levels, I think that's where the quality of care becomes extremely important. We give, by getting these certifications and accreditations, and it costs 130 million shillings every year to get Joint Commission, CAP, SANAs, CCPCs, and the infrastructure around it, people behind it. The Ministry of Health doesn't demand it. Most people don't understand it. But if you ask yourself, do you want to go in an internationally recognized institution? The answer is certainly yes. I think that's what the confidence that we are giving to our patients who are walking into our hospital, that you come to Aga Khan University Hospital in Nairobi, you will get the same quality of care as you would get it in North America or as you would get it in Europe.
Yeah.
And when we talk about Joint Commission, there is a book behind me. This is the 8th edition where we were audited. It has 1,200 measurable elements. 1,200 measurable elements. And they evaluate us on those 1,200 measurable elements. And we have to meet those measurable elements and those standards for us to be accredited.
And that sounds like a rather rigorous process. And like you said, it's not a requirement by the ministry or government. Why would you spend all of that money on getting yourselves accredited?
I think it's an interesting
and the time, because I can imagine getting yourself
it's a painful audit, absolutely.
On 1,200 elements. That must be quite rigorous.
So there is a philosophical answer and then there is more strategic answer. Philosophy is that we are in healthcare is very close to people's heart, right? So investment in quality is extremely important. That's a conscious decision that we as an institution made. The second part of the question is that people, and we have heard about this, that people travel to other parts of the world to get healthcare. Why do they go outside? Why? Either the care is not available in the country, or it is not available consistently in the country, or is not available of high quality in the country. People don't trust that if I go for, say, kidney transplant, I will come out alive, right? or it's available one day and not available the second day. So these are the reasons why people travel, right? Or it is not available at all.
Yeah.
Through investment in quality, this is the perception that we are trying to change. That if someone is sitting outside of Kenya and thinking of getting healthcare, we want to give that confidence to that African citizen that come to Nairobi, come to Kenya, you will get the same quality of care, not because Rashid is saying, because someone else externally has validated that you will get the same quality of care that you would get it in North America. That external validation is extremely important. When you go to school after the year end, you give annual examination, right? You don't tell your teacher, I've sat in the class for 12 months, just give me the certificate or a degree.
Right.
You give for the examination.
Yeah.
Why? Because then they want to check that whatever you have learned, you have actually learned.
Yeah.
And this is what the external validation is all about, right? We can stand on top of Mount Kilimanjaro and say we are the best, but who will listen unless it is externally validated?
Let's talk about specialist services. The sudden rising cases of, say, heart disease, cancer and diabetes, all of these are a big problem in this part of the world, not just in Kenya. So let's talk about specialist services and what you're doing or what more you think should be done to strengthen these specialist services to provide for these. And by the way, are these the only areas of concern that you see in the healthcare space?
Okay, that's a very important question. If you go back in time 10, 15 years, 20 years, Kenya and Africa in general was known for infectious diseases, HIV, TB, malaria. But now, sadly, unfortunately, the disease burden is shifting. 5 out of 10 deaths in Kenya, 50% of the deaths, probably more, are happening because of non-communicable diseases, heart attacks, diabetes, cancer. So the disease burden is rising. Now, how do we tackle this? There are multiple things that we must do. First is, an important thing is, be aware and do your wellness checks. Because if a cancer is diagnosed at stage 4 versus cancer diagnosed at stage 1, outcomes are different, costs are different, pains are different. So do your wellness checks. And we as Kenyans, and it's a sad reality what I'm going to say now, that we are late to everything. And I was talking to a friend of mine that if you have to go to Mombasa Road for a meeting at 11 o'clock, you leave at 10, you don't leave at 10:55. Right? Yeah. So, and that attitude is the same for healthcare. How many women in Kenya past the age of 40 gets their mammogram done regularly, pap smear test done? How many men past 40 do their PSA test done, right? So we are not conscious about our health. So that is one part. I think and everyone has to play a role. Healthcare providers have to play that role. Insurance companies have to play that role. Ministry and the government has to play that role to encourage that culture of wellness. So that's part one. These diseases will happen, but if we catch them early, then we can treat them better. The second part is, do we have the specialists to treat them? Yeah. In Kenya, over the past decade or so, I think we have invested significantly. Both public sector and private sector has done really well. But there is a still huge gap between the urban and the rural, right? Nairobi is not equal to Kenya, right? If you look at the quality of infrastructure and the availability of specialists in Nairobi is brilliant. But if you want to see a neurologist in Busia or in Kakamega or in Kitui, God help you. So there is a huge divide between urban and rural areas. So we need to train more. We need to train more and more specialists. So I think that is part number 2. And part number 3 is the investment in technology. I think, and again, the investment in technology has happened more so in urban areas as compared to rural areas. But I think with the government current agenda of UHC, and it's a beautiful agenda, I am all for it, universal healthcare. We are having teething issues now, we know, but the agenda is good, the agenda is beautiful, and I think this needs to advance within the urban areas, also within the rural areas, and the focus is and will continue and should continue to be on the primary care.
And the Aga Khan is a university hospital.
Yes.
So talk to us about the role in terms of training specialists, the specialists that you say are, sorely lacking and there's a shortage of.
Yeah, I think that absolutely. So His Highness the Aga Khan, our founding Chancellor Prince Karim Aga Khan, he made the decision 22, 23 years back to convert this hospital into a teaching hospital. Although this hospital started in 1958, so almost 70 years old now, but we did not start as a teaching hospital. It was a secondary care hospital, and then it grew. But in 2002, 2003, he made a very strategic, very important decision that treating patients is not enough. If you have to create a sustainable impact, then you have to train doctors and nurses. Because healthcare is very episodic. A patient is sick, comes to the hospital, you treat them and they go home. End of the chapter. But if you train a doctor, if you train a nurse, then you are making a long-term impact into the community and into the country. So that is why with the Aga Khan University Hospital. Now we started 22 years back, we started with the postgraduate training programs, which is the master's program. It's a 4-year residency program and 9 different disciplines: medicine, surgery, OBGYN, pediatrics, anesthesia, pathology, radiology, family medicine. Then 3 years back, we started undergraduate program in medicine. So people would start with undergraduate and then go to postgraduate. We did the other way around. We started with the postgraduate, now we started with the undergraduate training, which is a 6-year MBCSB program. But over the past 3 years, which I am extremely proud of, over the past 4 years, 5 years now, we are now doing specialized training. So if after your undergraduate degree, you do your postgraduate degree, so bachelor's and then master's. Then if you want to become a specialist, for example, a neurologist, an interventional cardiologist, a hematologist, then many a times people would travel to South Africa, they would go to Egypt, they would go to the UK and other European countries to get that specialized training, 2 years, 3 years training. And we saw many a times when people go to the other parts of the world, 7 out of 10 times they will not come back because they want to earn in dollars and pounds as compared to Kenyan shilling, which is changing now, by the way, because the healthcare is doing well in our country. So we said that how do we arrest that? How do we offer those training programs? Because we have the patient base, we have now started clinical fellowship program, which is the specialist training in Kenya. And we have now 15 specialized training programs. So we have undergraduate, we have postgraduate, now we have specialist training. And those 15 programs are, for example, medical oncology for cancer, very relevant today, unfortunately. Hematology for blood disorders, neurology, we have for gastroenterology for your gut health and stuff. We have neonatology we have pediatric gastroenterology, pediatric neurology. We have nuclear medicine. We have oncopathology. Those specialized trainings are there as well. And now those as these programs mature, as we churn out more and more graduates, they will be working for Aga Khan, but more importantly, they will be working for other parts within the country as well. So those specialists, the gaps that we were talking about, be it in cancer and others, those gaps will continue to fill. People will not have to go outside, neither for the training nor for healthcare.
And you talked also about the disparities between urban and rural areas. So this perhaps would be a move towards getting them more available in areas outside of the capital?
100%. Absolutely 100%. See, and if you look at cost of healthcare, cost of healthcare is also determined on the demand and supply, right? If the demand is high and supply is less, the prices will go up, right? We know that it's simple economics. If there are more surgeons, more specialists available to match the demand, then the pricing will stabilize, right? So, and that's where we are heading. So it's an economic answer, but also it's a healthcare answer.
And the two of them go hand in hand. Talking about, the sort of quality healthcare you can get here versus overseas, and I think we've talked about it. You've said how there's people who think, well, I can get the same, I can get better quality overseas. But then there's also the issue of just ensuring that, whatever healthcare is available on the continent, and you said for Africans that is a major issue. are there any partnerships you have to ensure that African citizens within the continent can get the right quality of healthcare without needing to go overseas?
Yeah, I think yes. Very recently, we have signed a strategic agreement with Kenya Airways. Kenya Airways, as we know, flies to over 32 destinations within Africa. The population of those destinations is almost 500 million, half a billion people connecting to Nairobi, Kenya. Through that strategic partnership, what we are trying to do and will continue to try to do is that they get preferential rate by the KQ to come. Before they come to Nairobi, they share their medical history, their scans, their labs with us, so our clinicians can look at it before they come to our hospital. Once they land in Nairobi, then there is an ambulance. If you are on a wheelchair or a stretcher, then there is an ambulance available, KQ ambulance, which we will transport you to Aga Khan. We have arrangements and agreements with the hotels as well. So if a patient is coming, most likely he or she will come with a family member. So where will the family member stay? So we have partnership with the hotels as well. And then so rather than going to other parts of
because that
the world,
sounds like an arrangement that we hear about in India.
Yes.
Right?
Yes.
Where you go in and there's, a whole package,
Correct.
medical tourism. You're saying now that is available here in Nairobi?
Absolutely, courtesy KQ and Aga Khan.
Okay.
Yes.
All right.
Yes. And it's in infancy.
Yeah.
It's a model that did not exist. So we are experimenting with many things. We will learn many things along the way. But the idea is 300,000 people and $7 billion leaves our continent. $7 billion leaves continent. And these are sample studies. No, I think the number must be much higher. I think Kenya has what it takes.
Mm.
Not only at Aga Khan, public and other private hospitals, they are doing remarkably well. That we can bring those patients to come to Kenya,
Yeah.
who are seeking good quality healthcare and good clinical outcomes, rather than going to an alien land where they do not even speak the language,
Right.
have spicy food and stuff. So
So all of that is now available here, but then the Aga Khan does treat patients from the region
Yes.
already.
Yes, absolutely.
There is others that come here for healthcare, particularly from the wider Eastern Africa.
yes, absolutely. We
Yeah.
see around 23% of our patients
Yeah.
are from outside of Kenya. And that number is around 3,500 to 4,000 patients, inpatients. I'm not talking about outpatient,
Yeah.
inpatient. Around 3,500 to 4,000 patients are coming to Aga Khan. But I think it's the tip of the iceberg. I think the opportunities, not only for Aga Khan, but for Kenya is much more.
2026 is coming. I mean, it's been one of those years. You've finally gotten your accreditation, but industry-wide and in the healthcare sector, where do you see some of the high priority areas, and what would be your priority agenda? I want to talk first of all industry-wide, that maybe government and other actors, even those in the private sector, need to focus on, and then we can focus on Aga Khan University Hospital's areas of priority.
Let's start with the government. I think then I'll come to industry, then I'll come to Aga Khan.
Yeah.
So as far as the government is concerned, as I said in my earlier remarks, that universal healthcare is a beautiful agenda. There are teething issues now. I think those teething issues needs to end. We need stability in the system, and I hope and pray that stability will come. That will allow Kenyans to access healthcare seamlessly across various counties and various hospitals. So that's one. Number two, the primary health agenda is a very important agenda. It touches on our earlier conversation about wellness, looking after people's health. The primary care is an important agenda for the government and for us as a country. If you look at the industry, I think industry has continued to expand, both public and private sector. That expansion needs to go into other communities and rural areas as well. I think there is a big divide between urban and the rural. So I think that is something that we have to do. I think the insurance industry is not growing as they would have liked. I think it's the insurance industry, they have to do things differently. so that there are more people insured. Right now, only the employed sector
Yes,
are
yeah.
insurance. But what about huge Juakali sector or unemployed or self-employed sector? I think they need to be insured as well. I think the insurance industry have to play a big role in that one. And price the products appropriately as well, right? If an item is costing you 10, don't sell it for 9. Then tomorrow you will have nothing to spend. Then it's not financially sustainable. So that is number 2. As far as Aga Khan is concerned, you must have heard our CS and Shah announced that some of the services are not available in Kenya and Shah will pay for it.
Yeah.
So for example, I think liver transplant is not available, and there were several other services. We are making conscious effort to bring many of those services, and other players within other healthcare providers are also making an effort to bring those services to Kenya. So a couple of years back, we have started kidney transplant program. We have partnered with Shah. It's a successful partnership. We have done, if I'm not mistaken, close to 20 kidney transplants so far, and successful. So now people don't have to go to other parts of the world to get kidney transplant. We are starting bone marrow transplant unit very soon. We are starting. We have sent our resident to South Africa for liver transplant training. That gentleman will be coming back, and over the next few months and years, we will be looking at liver transplant services as well. Next year we are starting, and it's less to do with care, but more to do with education and research. We are starting a next-gen sequencing lab as well. It's a $5 million investment in our research infrastructure, where we will be able to sequence the genes and do more research on the Kenyan and African population. So that is something that we are looking at. So our investment in new services will continue. Our investment in people, the fellowship programs that I talked about, will continue. Our investment in quality of care will continue. Our investment in expanding our outreach centers will continue. The 3 main hospitals that we have, Nairobi, Mombasa, and Kisumu. Besides these 3 hospitals, we have close to 100 outreach medical centers which are embedded in the community. That expansion will continue. We want to be closer to the patients. There is primary care in those centers, but now we are increasingly taking more and more specialized services to the outreach centers as well, because many of the services where people come to main hospital, they really don't have to come to the main hospital. Dialysis can be done very safely in an outpatient setting. MRIs can be done, consults can be done, labs can be done, physiotherapy can be done. So many such services can be done very safely and with good quality in an outpatient setting. So that's what we are. We have been expanding our outreach centers. As I said, we are almost in 25, 27 counties and close to 100 centers, and we will continue to invest and expand our reach through our outreach medical centers.
Yeah, it's a good place to leave it. Thank you very much for speaking with us. Rashid Kalani, who's the CEO of the Aga Khan University Hospital, on healthcare trends and quality of care in health sector. Thank you.
You're welcome. Thank you.